Cheryl, we have some scores and endpoints when you're trying to measure AD in clinical trials, like the IGA score. You were talking about that. What are some of them? Which ones do you like? Do you like the IGA score?
Well, we heard from the doctor that while it's great for the FDA to use in their very controlled clinical trials, it's not something that's used in the practice setting. And unfortunately, as we sit as specialty pharmacies working with the physician, prescriber community, working with the payers, we deal with criteria for use that can be different across the different payers, and we are trying to make the case for the individual patient for appropriate use of that.
But I'm talking about in the clinical trials. I mean, clearly we're gonna try to morph this into clinical medicine. But when you're trying to measure this for a trial, for a paper, you've got these various markers, right? There's the IGA, the BSA, you said the EASY score, the 5D pruritus scale. I'm not making this up, I'm reading this.
Yes.
Over here. Yeah. I'm cheating. You know, what is the utility and the meaningfulness, at least in terms of research on these things?
I think in the research, well, we heard that the FDA is very heavily depending on the IGA and the outcomes of that. You know, 70% I think was the solo scores, right?
Okay.
Greater than. Some were greater than 75%.
That's the IGA.
Right.
Okay.
Right.
So that's the,
I personally struggle with that a little bit, just because I agree. I think that's realistically what's going to be used because it's something you can actually apply to clinical practice. But when I look at a 4 or 5 point scale, I don't know how specific that is. I don't know where you go from a 2 to a 3 and what does that mean to a payer or somebody who's paying for this drug. So I prefer things like the EASI, just like I do with POSI and other things. But the challenge is those are used in clinical trials, they're not used in clinical practice.
which brings us back to Jonathan. Out in the real world, we have all of these studies, and the studies are using some marker they've got to judge these drugs by and efficacy by. But in the real world, can you use any of these to treat patients?
So yes and no. I want to double back just for 1 second to the trials outcomes. It's been the Wild West for decades in terms of which assessments should be used, and there's a ton of different pseudo-objective assessments out there. There's an attempt to really harmonize things internationally, and there's this harmonizing outcome measures in eczema or home group. And they've picked 2 winners. One is this eczema area and severity index, the EASY, and then scoring atopic dermatitis or SCORAD. EASY was developed in the US, SCORAD is developed in Europe. They're both good because they account for both the severity of the lesion as well as the extent of it, so just how diffuse the disease is.
Okay.
So they're hard to do, but they're now sort of accepted standards that you're going to start to see all future systemic studies, you know, or studies of systemic agents using these, and that will hopefully help for comparative efficacy research and things like that.
Okay.
Real world, it's hard. You know, the EASY score is analogous to the PASI in psoriasis. No practitioner wants to use these. They're hard to do. It's hard to do the math. It's cumbersome, and they're not always, you know, they're not always reliable outside the trial setting because it takes a certain amount of training. You know, we do this all the time, so we get it right, we think. But in the clinical setting, where you're seeing 1 or 2 of these a year, or who knows, you know, how reliable is that assessment? So I think, you know, when you look at body surface area, this is a reasonable one that some patients, you know, could rely on. Certainly, even if the lesions were mild, but were absolutely everywhere. And then you're talking about patients who haven't responded well to topical agents. I think that's one that probably most of us would be able to agree on. What that cutoff is, I think you could have a discussion on. You know, when you look at, but then at the same time, there's some patients who may have more localized disease, but that's so refractory, so intense, it may cover 5% or 10% body surface area, but nothing else touches
Well, this sounds really complicated.
Yeah.
And what is a reimburser going to do? Are you going to be able to give a reimburser a score based on, this is a 10, either it's small but bad or mild but big, and how can you do that in the real world? Does that work?
I was going to say we like yes and no. We're not going to get it. We generally don't have it, but we would love it.
Well, I mean, and I guess I throw that back at you. What, you know, would you be comfortable with something like a combination of body surface area and the fact that they've responded or not responded to existing
I think that's where we're
treatments?
going to shake out. Yeah.
Okay, well
But
then
I think you're going to need to make sure that the pruritus and other things are included in that because you know, the intensity of that is part of what really distresses patients the most.
I think what's tricky